I'm Dr. Helane Fronek, and I'm here with my friend and colleague, Dr. Mel Rosenblatt. And Mel, there are a lot of things that I've always wanted to ask you because you do some pretty specialized treatments. I know that many of our patients come in with varicose veins that develop during pregnancy or that get worse after pregnancy. If a patient comes in to see you and they are pregnant and they're really suffering from their varicose veins, they have a lot of pain, what do you usually tell them?
Well, it's an excellent question. There are things that they can do during their pregnancy that will alleviate their discomfort. Exercise, the use of compression stockings is really critical to alleviating the discomfort that they'll have. We make sure that they get appropriately fitted, and sometimes they have to use different size compression stockings during the course of their pregnancy as they grow. Usually a pantyhose type stocking is what's recommended. For patients who have very high varicosities, it gets a little more complicated because it's very hard to get compression in the upper portions of the thigh. And it's a difficult thing to manage. Very often these patients are in a lot of discomfort, and there isn't a tremendous amount that we can do. Treatments that we normally would do for patients who are not pregnant are not really recommended here in the United States. There are some who will inject veins overseas because there's no data as to whether the chemicals that we use to do these injections are safe during pregnancy. Other options are, there are some very fine and elegant techniques where we can remove one or two veins in critical locations that can reduce the pressure down into the legs and make them feel a little better as well. And those are some things that can be recommended to the patient when they're pregnant. The critical thing is that once their pregnancy is done, the question is, what do you do about their veins?
And so what do you tell your patients when they come back?
That's a question that's asked to me all the time, and many patients will walk in saying, you know, I've been to the doctor and they said don't do anything to my veins until I've had all of my children.
Right, I've heard that so many times. How do you respond to that?
Well, my response is that especially after they've had a very difficult pregnancy, at least with their veins, I say, well, it's very likely that your next pregnancy will be even worse. Mm-hmm. And it is true that you will likely have some recurrence after your next pregnancy if you decide to treat now, but at least this pregnancy you will not suffer nearly like you did in the past. So I do recommend treating the varicosities after a short period after the pregnancy, because some of the vein problems will resolve physiologically on their own within a few weeks after pregnancy, but those that remain are probably likely to remain and worsen with the next pregnancy. And so I do recommend treatment for those patients.
You know, you and I are in agreement about that. I generally tell people that we'll treat your veins maybe 6 weeks after they stop nursing. Mm-hmm. And I think that that attitude that we shouldn't treat people's veins until they're finished with all their childbearing years really came from the fact that the older treatments were not that good. And we knew that people would get more veins as they would go through another pregnancy, and the treatments were difficult to go through, so we never wanted to have to do that again. Nowadays, I think that we're luckier as phlebologists because we have treatments that work really well and are so much easier for our patients to go through.
Yeah, I couldn't agree with you more. And that's clearly a message that is not in the mainstream and should be out there, because so many of these patients have been told that, you know, there's nothing we can do for you, and they really go through some very difficult times during their second and third and fourth pregnancies.
They sure do. One of the things that does develop during multiple pregnancies is the development of varicose veins in the pelvis with something that we call pelvic congestion syndrome. Can you talk a little bit about that?
Sure. That's something that I take care of a lot. I see a lot of patients with that problem. Many patients won't even tell the doctor that they have a problem that is related to a pelvic problem because they're embarrassed about where the veins are located. But many of these patients really suffer quite a bit. And there are kind of two groups of patients, some who have pain in their legs from this pelvic source of veins, and some who have pain in their pelvis from these pelvic veins.
When you say pelvis, what exactly do you mean?
Well, we're talking about veins around the uterus that can arise from different causes. And there are basically three main causes. Pelvic congestion syndrome, which you just mentioned, is a syndrome where the veins that drain the uterus and the ovaries are a little unusual. and they actually have to go up towards the kidney veins before they drain into the normal circulation. And there are valves in those veins that drain upward, and many patients don't either have those valves or those valves go bad over time. And instead of blood going up towards the heart, the blood actually comes out of the kidney and goes down into the uterus and congests there, or pools there in the uterus, and causes these varicoses to form, and these varicoses then extend downward along the pelvic floor and into the vaginal area and into the thighs and down into the legs.
Wow.
And it can be very, very uncomfortable, especially during pregnancy.
Yeah. You know, I have also seen in my practice people who come in and their marriage is on the rocks.
Oh, yeah.
Because they have so much pain after intercourse that they become very disinterested in having any kind of intimate relationship with their spouse, and it really becomes a big problem for them.
No, absolutely. What's interesting as well is that in addition to pelvic congestion, and the patients that you're talking about might be in this category, patients will have what we call vaginal venous malformation or pelvic venous malformations. And what that is there are patients who are born with an inherited condition where veins don't form normally in and around the uterus. And these veins are in a location where they're not seen, and therefore no one knows about them until they enlarge during a pregnancy. And when they do, they become very painful. And that particular group of patients are the ones that I see have these type of problems. And marital problems and divorces can occur as a consequence of that. And these patients are a little more difficult to fix, but certainly easily fixable.
So you do a lot of things that I don't do. So could you explain, if I were a woman who came to you after having a couple of pregnancies, and I did have pain in my pelvis or pain in my vulva, what would you do for me?
Okay, very good. So patients who come to us with veins in the upper portion of the legs and the upper portion where the legs meet the pelvis very often have a pelvic source, but we don't always know exactly what it is. Is it this pelvic congestion syndrome? Is it coming from a malformation? What is the exact cause? Very often, though, these patients will get much better with just some very simple injections into these veins that are in that location. So without involving them in a complex procedure, you can treat them in the office and make these patients much better. There is a group of patients who won't get enough symptomatic relief from that, and those are the kind of patients that I tend to see and do more involved procedures. And those involved procedures often utilize X-ray equipment. And why are we using X-ray equipment? Because it's very difficult to view the structures in the pelvis without X-ray equipment. But by using X-ray equipment, we're not doing any surgery, we're not cutting open any skin. Very often we can put a small little needle into the veins in the upper portion of the leg, inject some material that's visible on X-ray, and then follow it to where it goes with the X-ray machine, and then administer medication through that very same needle.
That sounds pretty precise.
It is, but it's not very invasive. It certainly requires precision, but not very invasive to the patient. Very often, it's the size of a needle puncture that we make. Patients who have pelvic congestion, oddly enough, to treat those veins, we go from a neck vein to get down to that location and treat or block those veins that are abnormal.
What's that like for a person to go through?
Well, just to give you an idea how non-invasive it is, we do this in the office. I mean, not every office has an X-ray machine, but those that have that, as I do, you can do that in the office setting. So it is not a very painful procedure, and the patients go home pretty much very, immediately after the procedure. And it takes about an hour to an hour and a half to do on occasion. It's all done internally, and luckily there are very few pain sensory fibers inside the veins, and therefore the patients don't feel much of what we're doing, and they go home with a Band-Aid on their neck.
And how long until they feel better?
Usually about 10 days to 2 weeks is when we'll start seeing patients feel better. On occasion, we've had patients with such severe disease that when they leave the procedure room and go to the recovery room, they feel better already.
Whoa, I bet they are so happy.
They are. I had a patient once, a very interesting woman, who had vein problems in her legs as well as her pelvis, and we treated the vein problems in her legs, and she said to me, Doc, my legs look so much better, but they still feel miserable. And I said, well, we have to look at what's going on in your pelvis. And we did, and she did have this pelvic congestion syndrome, this problem with the vein there, and we did fix it in the way I described. And literally, as soon as she got off the table, she said, you know, finally I feel better. And that woman is so grateful that she comes visit me every time she passes my office. She lives in New Jersey, but comes, you know, whenever she's passing by, she'll come in and say hello.
Yeah, I bet you really changed her life.
She says so. Hard for me to believe that.
But I bet it's pretty gratifying to see this group of patients.
It is.
It's a group of patients who seems to get not really ignored, but nobody pays a whole lot of attention to them. And as you alluded to before, it's somewhat embarrassing to come in and talk to a doctor, even though they're a doctor, they're still a stranger, about these very personal things.
It's even more severe than that. I'll go one step further. Besides the embarrassment, sometimes women will come in and they'll tell their doctor that they have this problem. And the doctors will say, well, you know, I see a lot of women with veins in that location. They're not in this much pain or discomfort. And I see patients who come in after having seen many doctors, even had many surgical procedures such as hysterectomies, still in pain, and eventually they're labeled as hysterical patients or crazy, or, you know, they're sent to pain management physicians to deal with their pain. And very often what the physicians are all overlooking is some sort of venous problem inside the pelvis. And that's a group of patients that I see very commonly, those are the patients who you will dramatically change their lives by fixing them.
It sounds like we have a big job to do, educating our colleagues about this syndrome and the fact that there are things that we can do about it.
Oh, yeah. Oh, yeah.
What about the patients who come in with just a few veins in their vulva, around their vagina? What do you do for those people?
For those patients, if they're asymptomatic, if they're not having any pain or discomfort, there's probably not much to do. For those who are having discomfort associated with that, or for one reason or another it bothers them, those, as I said before, I think can be injected in the office. Most phlebologists will handle it in that fashion. It might be a little embarrassing or uncomfortable for the patient, but it usually has a very excellent result.
Okay. I've done those kind of injections, and I've always been impressed that, according to my patients afterwards, they have an idea that this is going to be really painful. And not that it's not uncomfortable, but it's much less painful than they really feared that it would be. Is that your experience also?
That is my experience exactly. I mean, I find that patients have more sensory findings and more pain when we inject veins on their ankle than when they do injecting veins in the upper part of the leg.
That is absolutely true, isn't it?
Yeah.